recording this now. I will let people in as we go because I know people are still running to join us, but we will start. So just a very quick hello from me, and obviously welcome to this afternoon's meeting. I'm going to move us on straight away without doing any recap of the last meeting. We'll do that at the end, should we need to, just so that we can go straight into the speakers and have some good quality conversation. If you could keep yourselves on mute whilst you're not speaking, that will be a great help to avoid any disturbances. And then obviously we can make sure that we're hearing the people that are speaking with us. I think we've got Claire and David up first from the UK Health Security Agency to talk to us about homelessness and health protection. So if I hand straight over to you two, that would be brilliant. Thank you very much for joining us.
Thanks, Tracy, and thanks, Karen, for helping arrange this as well. I'll start. My name's David Roberts, consultant in health protection with UKHSA South East, specifically the Thames Valley team, and joined by my colleague Claire. I hope you don't mind, I'll introduce you for brevity, but Claire's another consultant in health protection, again with UKHSA South East and the Thames Valley team. I'm going to turn my camera off, so I'll keep turning my head from side to side. That'll put you off. But what we wanted to cover today was some general principles that we work to, and then look at some specific infectious hazards and disease threats that are most relevant to our health protection practice. So it's not necessarily a comprehensive overview of all infectious disease threats in people who are homeless. And we'll end by talking about contacting the HPT and when you might do that. And just to be clear about, we've adapted some of these slides from other sources and we've listed those there. Okay, thanks. So HPTs, health protection teams, we are the local response to health protection related incidents, and we provide specialist support as listed there, particularly around infectious diseases, but other hazards too. And we can also help with local disease surveillance, alerting, and the bulk of our work is managing health protection incidents and outbreaks, so single cases, but also outbreaks as well. Okay, can we move on to the next slide? So I thought this was quite a useful graphic. It's from Liu et al. It's referenced in the bottom right-hand corner. But I think we're all aware that homeless persons have much worse health and life expectancy than average. And it's recognised as having this so-called trimorbidity of physical, mental illness and substance use disorder. And that's the sort of immediate downstream consequence of non-communicable and communicable diseases listed in the bottom box on the left-hand side. And upstream, there's the causes of those downstream issues include significant social burdens, exclusion, and barriers to healthcare. So I've highlighted in a red box at the bottom that infectious diseases, and that's our main role, but we do need to consider its place in the wider context of health in the homeless population. And then looking at the right-hand side, you can see that the interventions to address health issues in homeless population must address the intersecting health and social burdens by combining health-related and also social interventions as well. Okay, next slide, please, Cam. This slide is just pointing out that when we talk about the homeless population, it will significantly overlap with other vulnerable populations. For example, people who've got a history of imprisonment or people who may be sex workers as well, and or overlap with other high prevalence of risk factors or risk behaviours, for example, drug and alcohol use or frequent unprotected sex. So in this particular example, this is from tuberculosis, and it shows social risk factors. Can we just check everyone's on mute, please? I've got some feedback. Okay, thanks.
We've got some echoing going on.
Okay, let's try that now. So what this shows is TB cases between 2013 to 2017 with a social risk factor. It's not all TB cases, it's all cases with a social risk factor, with these 4 social risk factors. And it just shows the overlap between them. So for example, there's just over 1,000 people who are homeless, and then of those, about just 150 or so, for example, had a history of drug misuse. And so more than half, or just about half of those who are homeless, or listed homelessness as a social risk factor, had one of these other social risk factors as well. So I suppose this shows that vulnerable populations are at greater risk due to environmental or behavioural risk factors and or their prevention needs not being met, and that these groups may not be able to access healthcare to prevent further transmission and adverse consequences. And what that leads to is worse outcomes at a person level in terms of disease severity, but also at a population level, you get sustained epidemics if prevention and treatment needs aren't met. So when we talk about specific interventions, it's worth thinking about how that's integrated with other parts of the health and care system and health and care that person receives. Oh, thanks, Karen. Yeah, next slide. So we have to remember the importance, particularly of primary care, registration with primary care, important prevention services, immunisations, for example, access via primary care, and also think about access to care. And I've put the example of this yellow card that you can download from the Migrant Health Guide. You can give to service users, but critically also to staff, just to remind people about people's rights to access to care. And when we think about care, it should be integrated, and Pathway produces standards for commissioners, services for homeless and inclusion health populations, and considering patients' wider needs, their physical, psychological and social care needs, and how their complex care can be managed well and in a culturally competent way. So care should be integrated, and for example, you shouldn't just be offering BBV, bloodborne virus testing, but also you have to think about linkage to care, harm reduction if there's risky behaviours, and also wider social care needs that may contribute to a person recovering well. Okay, next slide, please. And Claire, you're going to take over from this point.
Yes, thanks, David. So I'm just going to go through a few infectious diseases, starting with hepatitis B virus. So in the acute phase, it's a flu-like illness, and which is not particularly distinctive. So quite a lot of people won't realise they've had acute hepatitis, or they're picked up through routine blood tests later on when they have chronic infection. But most adults, most people clear the infection after the acute phase and don't go on to develop chronic Hep B. So 90% of adults clear the virus, but this is age dependent, and in the younger ages, you're less likely to clear it. So if you're infected perinatally around birth and after shortly after birth, only 5% actually go on to clear the virus, so the rest develop chronic infection. And the issue with this is that 20 to 25% of people with chronic infection have progressive liver disease. And although there are treatments available, antiviral interferon treatments, these aren't curative, although can be effective in progression. It's transmitted parenterally through parental exposure to infected blood or bodily fluids. So this could be either sex, blood to blood, such as intravenous, and perinatal. And the WHO classifies different countries in terms of their infection rate, so presence of surface antigen, which indicates current infection. So you have high, intermediate and low prevalence countries, and the UK is a low prevalence country. As you can see from the details there, 0.4% of those having antenatal screening, those mums doing the antenatal screening, they have a surface antigen present indicating current disease, and 0.3% of people who inject drugs. Although amongst those who inject drugs, there's a much higher proportion that have got antibodies that have been infected previously, detected through the presence of the core antibody. Thank you. In terms of control and prevention measures, it's an acute hepatitis B, as with the other hepatitis, are notifiable diseases. So one of the key things is to give advice to limit infectivity to others. So using condoms, etc., not sharing needles, and not sharing razors, toothbrushes, etc. if you're in a household with somebody with hepatitis B. There's obviously contact tracing as well for close contacts who require testing and post-exposure prophylaxis. This could be household contacts or sexual contacts, and those who share syringe and drug taking equipment. And there's post-exposure prophylactic vaccination following sharps or needle stick injury. And one thing to flag here that we've come across as health protection teams, that quite often there's limited occupational health cover in homeless hostels, and it's really helpful, important to have this cover to help in if there are any exposure incidents. And I'll come on to vaccination now, because there's a very effective vaccination available, and from 2017 I think it became part of the Universal Childhood Vaccination Programme. So babies born in the UK now receive or are offered a Hep B vaccine as part of their childhood vaccination programmes delivered with the other vaccinations. And there's also selective pre and post exposure programmes. Other things to help prevent disease and reduce transmission as opportunities for testing and early diagnosis, so either opportunistic or screening in pregnancy, harm reduction, as I mentioned, in people who inject drugs, and condom use. Next slide, please. In terms of vaccination, there's a large overlap in the indication vaccination of those most at-risk populations. So NICE guidance highlights that people who inject drugs, either current or intermediate or like to progress to injecting drugs, should be vaccinated, as well as their cohabitees and sexual partners. Those who frequently change sexual partners, such as sex workers and some men who have sex with men, close family contacts of persons with chronic Hep B, and inmates of custodial institutions. So you'll find that obviously there's quite some overlap with homeless people in these populations, and it's really important that those at higher risk are offered vaccination as soon as possible. There's also individuals at occupational risk. So this would include, for example, healthcare workers and people working in prisons. In terms of the homeless sector workers, there's not clear guidance on this, and it's really a risk assessment approach for this sector. But I would say if staff are likely to come into contact with blood and bodily fluids, then it would be advisable for them to also receive a course of Hep B vaccination. And there's further details of that in the Green Book. Next slide, please. And this slide here, graph, just shows you the percentage of people who inject drugs who are vaccinated, which unfortunately has declined in the last 10 years from 76% in 2011 to 66% in 2020. Thank you. Next slide. Hepatitis C, another hepatitis which you may well have come across. Again, it affects the liver and especially contact with blood. It's less infectious than Hep B and is less common in the UK than some other parts of the world, but certain groups are at increased risk. And as I'm sure you're all aware, that in the UK, the most common risk factor for hepatitis C is sharing or having previously shared injecting drug equipment. And we think around 1 in 5 people infected will clear the virus straight away, but the rest will develop chronic disease. Although there's no vaccine available at the moment, there's very good treatment options, and this has really improved in the last 5 years. So we now have directly acting antivirals, which are oral treatment, much more palatable than interferon treatments that were available previously, and they cure 95% of cases. So there's a big push both by NHS England and WHO to eliminate hepatitis C by 2030. And we're hoping in the UK to do it before 2030, so to prevent transmission within the UK. We're well on our way to reaching the goal in terms of morbidity and mortality, thanks in large part to the availability of this treatment and the success of this treatment. However, although the prevalence is going down, actually new infections are not really decreasing. We've seen from recent reports. So the control measures, I've talked about the treatment. I think somebody's just mentioned the TRATs, some other options that are available. So about immunotherapies on the way for B&C, so thank you for that. And again, needle stick programs, opioid substitute therapy. So that's all very important in preventing infection in the first place and preventing getting reinfected after you've been successfully treated. Thank you. Next slide. So this is just showing you the decline in the number of people with chronic hepatitis C. It's declined by 37% in the last 5 years, which is great news. And most of the cases are people who either currently inject drugs or have injected drugs in the past, but this is not all cases, and certainly in parts of the world, such as parts of Africa, including Egypt, parts of the Middle East and Asia and Central Asia have high rates of Hep C. So that's also the other groups as well, but to be targeted for hepatitis C testing, although most of the cases, as I said, in the UK are people who have injected drugs. Next slide, please. Despite the availability of the treatment and testing, although there has been impact of COVID, you'll be well aware due to on services, more than half of people who inject drugs may be unaware of their chronic infection. So it's still really important to undertake more case finding and testing in this population and decrease awareness. Next slide, please. And then around 2 in 3 people who injected psychiatric drugs participating in survey in 2019 and 2020 report adequate provision of needle and syringe to meet their needs, which obviously means that a third of those people surveyed do not have adequate provision of needle and syringes, which is a risk for Hep C and other bloodborne viruses. Thank you. Moving on to something slightly different, a respiratory bacterial infection. So the good news is generally that TB rates have been declining. However, England still has some of the highest rates in Western Europe, and globally, TB is still a huge problem and is the second biggest infectious disease killer, with COVID-19 currently being the first. We've unfortunately seen an uptick in rates in 2021, though we had a general decline in the last 10 years. So we think this increase is probably because of disruption to TB services and primary care during the pandemic, which has resulted in some late presentations to healthcare and delays in referral. So in terms of control measures for TB, early access to testing and treatment is really important. We have effective treatment available, but it's more effective if it's captured early before the disease progresses far. There's also BCG vaccination for higher risk groups. This is generally offered to infants who are either from live in a high incidence area in England, or whose parent or grandparent is from a high incidence country. It's sometimes offered to also to new entrants that are under 16, and occasionally for 16 to 35s who are in high risk occupations. So that might be laboratory or healthcare workers, but it's not now universally offered to everybody as it was previously, school age population. This is primarily because it actually is helpful in reducing the risk of childhood TB, such as meningeal TB. Really important, I think, for the homeless population and for others is just awareness raising about TB and about the symptoms of pulmonary TB in particular, that not every cough is COVID. And if you've got a persistent cough for more than 3 weeks, then you should seek medical attention. So linked to this is the importance of GP registration and being linked into primary care, so it's spotted early on. I mean, it might be TB or it could be something else. So and And there's also, I was going to say, new entrant screening program, but unfortunately not every area offers new entrant screening because of the commissioning arrangements, but this is for people from high incidence countries. So lastly, just on TB to say, it's a disease of inequalities, although it can affect anybody. We've seen that actually in the last 5 years, the proportion with social risk factors have increased, and that includes homelessness, a history of being in prison, on drug and alcohol abuse. And those people are also more likely to have more adverse outcomes. So it's really important that we tackle TB in all groups, especially in these sort of harder to reach groups. Next slide, please. Thanks, David. I'll hand over. Thank you.
Yeah, taking back over from here. Thanks. So HIV, people much more is very well known about, and untreated lead to immune damage and reduces your ability to fight infection. However, it's eminently treatable, and people living with HIV can now have a normal life expectancy and prevent development of AIDS complication of HIV. It's usually transmitted through unprotected sex with an infected partner, but it's also a bloodborne virus and can be transmitted by sharing needles. Control measures is in terms of healthcare workers, to use standard personal protective equipment, and for the general public is to practice safe sex and avoid sharing needles. Early diagnosis is really important, and regular testing for HIV and other bloodborne viruses should be promoted in high-risk groups. And there's a table I'll come to at the end where I've summarised and attempted to summarise the various bits of guidance around testing. There's also a reference to high and extremely high prevalence areas, because the particular testing offered will vary by the prevalence that you're in, prevalence of the area that you're in, and this particularly refers to opportunistic testing in healthcare settings. And then there's partner notification, which is essentially contact tracing and informing sexual partners of people who have HIV that they should seek a test. In terms of early treatment, if you have HIV, then taking antiretroviral treatment, ART, can result in you no longer being infectious to other people, and at a population level that can effectively reduce transmission of HIV as well. And then there's pre-exposure prophylaxis, which involves HIV negative people taking antiretroviral medicines daily or just before and after sex to prevent acquisition of HIV themselves. Thanks, Karen. This slide just summarises the HIV prevalence in local authorities in England. This is 2018 data. As you can see, it goes from 0 up to more than 5 per thousand, and above 2 to 4.99 is defined as high, and above 5 is extremely high. I stress this is in the UK context. It's really not very high at all in the global context. But the highest prevalence areas in England are clustered around urban centres, and in the South East we've only got one extremely high area, as it's called, around Brighton, but there is some clustering in other urban areas too. Okay, next slide, thank you. So bacterial infections, we see some of these reported to us in health protection teams. There's several sort of organisms or issues, but they are particularly associated with injecting drugs or injecting drug use. Invasive group A streptococcus is also known as IGAS, and then you have the staphylococcal infections, that's methicillin sensitive, MSSA, or methicillin resistant, MRSA, and then toxin producing bacteria like tetanus, anthrax, botulism, and injecting site infection. Really we see, oh sorry Karen, yeah. It's worth mentioning IGAS specifically, invasive group A streptococcus. This can be carried on the skin and or in your throat, and on any given day, a small percentage of the population will be carrying this, and it won't cause a problem, but it can, in some more susceptible individuals, lead to invasive infections, particularly if there's a portal of entry for infection, like a wound. And invasive infection is very serious and can be fatal. IGAS is notifiable. We do contact tracing around cases and give the contacts warm and informed information. If they're showing signs of early infection, they can have early prophylactic antibiotic treatment. For the toxin-producing bacteria, there's real public health significance because the spores can contaminate drugs at any point in the supply chain. Fortunately, it's very rare. I mean, it says in this from Shooting Up report, there are no cases associated with these in 2020, but we can see outbreaks, and they can be extremely serious when they do occur. And then finally, injecting site infections can be sore and open wound, and it's particularly associated with high risk injection sites where there's more likely to be bacterial colonization on the skin, for example, in the groin. And these can be serious because they can lead to surgery and, as I said, be a portal for more severe infection as well. Okay, next slide, thank you. So this graph shows IGAS isolates with injecting drug use recorded as a risk factor over time between 2000 and 2020. And it shows that there was low numbers recorded until around 2016-17. We started to see quite an increase. In 2018, there was an even bigger increase into 2018 and sustained in 2019, though there was enhanced case finding initiated then in response to this increase in reports of IGAS from prisons, people inject drugs, and homeless populations. So that will account for some of that rise, but nonetheless, there has been an increase. And then in 2020, that was lower again, still a relatively high percentage at 7% of isolates. And that was post-lockdown, and as it says, it's not clear exactly why that happened. There's reduced contact, but there could have been reduced testing and reporting as well due to the pandemic. Okay, thank you, Karen. This slide is summarising about risk behaviours. It shows sharing of injecting equipment among people who injected drugs on survey, and it shows that over time, there's been a sustained, if not indeed an increase in reports of sharing of needles and syringes and sharing of any injecting equipment as well. Okay, thank you. Next slide, Karen. So that's obviously of concern because it can lead to bloodborne virus transmission. There's some messages around risk behaviours that includes reuse of injecting, sharing and reuse of injecting equipment, but also around control and prevention of infections and injection site infections. So what we'd advise is that drug and alcohol services should facilitate easy access to needle and syringe programs and opioid substitution therapy, embed regular opportunities to discuss safe injection practices with clients, and provide low threshold and outreach wound care services. There's also specific low dead space equipment that may reduce the risk of bloodborne virus transmission further as well. And services should support communities to access harm reduction services, regular bloodborne virus testing and care. Okay, thanks, Karen. Next slide. Finally, we should mention COVID-19 and other acute respiratory infections. I'm sure we're all very familiar with them now. But of course, the homeless population is likely to be at higher risk of infection, and not only that, but also more severe outcomes from COVID-19, but also other respiratory infections such as influenza, and less able to manage risk of transmission of infection to others. Control measures are listed there. Seasonal influenza, there are specific eligibility criteria which are likely to overlap with those in the homeless population likely to be eligible, and COVID-19 vaccination is, everyone's eligible, entitled to at least 3 doses. Wait and see what the plans are, but the latest from the JCVI is that they're operationally, for operational purposes, they're looking at an autumn vaccination programme for those at higher risk of severe COVID-19 is looking more likely. There's other control measures in terms of environmental and hygiene measures. In terms of testing, we're still at a point just where we're able to offer asymptomatic, that's through LFD testing to manage risk, although we don't currently recommend routine LFD asymptomatic testing, and symptomatic PCR for anybody with symptoms. But from the 1st of April, there will only be limited community symptomatic testing for a small number of at-risk groups, and we're still waiting for final definitions of the eligibility. Still recommend use of face coverings, particularly in enclosed spaces, and most particularly around. I mean, cases should hopefully be isolating away in a room, but if the person is known to be a contact of a case, it's more important to wear a face covering if they do have to mix with others. And then I've mentioned isolation already. And the sector guidance, I understand, is due to be updated from the 1st of April, so we'll have to keep an eye on what comes. Okay, next slide, please. Oh, back one, there we go. So just to explain in terms of how and when to contact us. We don't have really fixed criteria for when to call us for a lot of these, but we are, we offer a 7-day-a-week service, though on call will just be dealing with emergency measures, and those are the methods that you can contact us. But we're always here to discuss if there's complex issues, particularly outside of guidance that's published, and or you're seeing more severe respiratory or other outbreaks, or you're concerned, then do get in touch. If it's not within the South East, just click on that link. You put in the postcode of the setting that you want to get advice for, and it'll tell you which team to contact and the contact details. Okay, next slide. And I'm not intending to go through this table, it's rather complex, but it's just a summary of the different guidance around when to offer vaccination and testing for the different risk groups, which frequently overlap with the homeless populations, linking to NICE guidance in the main. Okay, and that's it. Thanks very much.
Well, David and Claire, I didn't think you'd get through all of that in your time, but you did, and you did it brilliantly without it feeling rushed. An awful lot of information there, and it was really good to have the refresher, and fantastic in terms of the updates around the treatments as well. I started my career in the 90s in HIV, and obviously hepatitis was another bloodborne virus we were dealing with, and there was just nothing. It was a bit of a void. So it is fantastic to see how treatments have come on, but interesting to offset that against that revolving door of new infection and repeat infection, and how we'll tackle that. So I think that is a really good focus. We haven't got long for questions, but certainly we've got a couple of minutes to take any urgent ones, but I'm sure both David and Claire would be happy to receive any in the chat after the meeting as well. Any urgent questions from anybody?